What's up, Ninja Nerds? Today we're going to talk about pneumonia. So let's go ahead and get started. All right, Ninja Nerds, so let's go ahead and get started with the pathophysiology of pneumonia. Well, first off, what is pneumonia? If I were to ask you just a general definition of pneumonia, what would you say it is? Pneumonia is just the infection and inflammation of the lung parenchyma, the lung tissue itself. Now, the question is, how do we acquire this infection and this inflammation of the lung tissue? There's two main ways. We'll talk about a semi-third way, but the first one that I want you to remember is going to be inhalation. So inhalation of some foreign pathogen. Okay, you'll see that whenever we talk about these, the most common pathogen that's causing pneumonia is going to be bacterial, 75 to 80% of the actual infections. Another situation besides inhalation is going to be aspiration. So another one we'll talk about is called aspiration. Now aspiration, all of us at some point in time of our life have experienced this, where food or fluids has gone down the wrong pipe, if you will. And whenever that happens, generally what should happen is we should have some defense mechanisms that our pulmonary system provides us. One is you immediately should cough. And that coughing is designed to be able to work that actual food or fluids back up to spit it out or swallow it, instead of it going down to the respiratory system, right? Now, there is situations where aspiration, however, can become more common, and we'll talk about what are those situations where people can develop aspiration pneumonia, particularly of anaerobic bacterial etiology, and we'll talk about that. Another one we'll talk about, it's not as common, but it can be common in IV drug users. It is Staph aureus, so hematogenous spread is another one. It's not that common, but it can be in those who are IV drug users, particularly the bacteria Staphylococcus aureus. Again, we'll get into that a little bit more later. But these are the two ways. Now, again, I already mentioned that we have some defense mechanisms to prevent us, because we normally are going to inhale pathogens. We're normally sometimes going to experience aspiration. The aspiration just can also be due to like regurgitation. So sometimes if people have some underlying swallowing issue, like a Zinker's diverticulum or achalasia, where they're more prone to having regurgitations, that can also increase the risk of aspiration as well. But normally, we have defense mechanisms. What are those? I want you to remember these, okay? The first one I want you to realize is you have these things, these cilia. They're little cytoplasmic extensions that help to be able to beat mucus and large bacteria upwards so that we can either spit it out or swallow it, right? Preferably, you'd probably want to spit it out. But again, that's going to be these things right here. But the tissue which contains the cilia, which are commonly within the respiratory system, I'm going to abbreviate it here for you. It's pseudo-stratified ciliated columnar epithelial tissue, PCCE, pseudostratified ciliated columnar epithelial tissue. Again, that's one big defense, is this cilia. The second defense is, we already talked about it, what should happen if food or fluids go down through your respiratory tract undesirably? You should have a cough reflex. So there should be another situation where you'll have a cough reflex. So one should be the pseudostratified ciliated columnar epithelial tissue, beating up the large bacteria and mucus upwards, and the food if there is some type of food or fluids coming. And the second thing is, it's going to be the cough reflex. Another thing is lining the mucosa of our respiratory tract, our GI tract, a lot of even our genital urinary tract, is these little suckers here called antibodies. So you do have these little antibodies here, and these are called your IgA antibodies. These are a part of your mucosal immunity. So these are also little antibodies that are within the mucosa of this epithelial system within the respiratory tract that also can bind on to certain types of foreign bacteria or pathogens and trigger the immune system, right? So that's the third thing. So a third thing would be your IgA antibodies. So we got pseudostratified ciliated columnar epithelial tissue, we got our cough reflex, we got our IgA antibodies. What's the fourth one? The fourth situation here that is a part of our normal pulmonary defenses is going to be our macrophages. And these are specific. Now macrophages, you have fixed macrophages, and then you have other macrophages which can be kind of all around the different tissues. This is an example of a permanent or resident or fixed macrophage. They're called alveolar macrophages. This is our fourth defense system, okay? And these are really important for being able to phagocytose, engulf foreign matter, and then in response to that, secrete cytokines that pull in other immune system cells via chemotaxis to come and digest or break down those actual bacteria, as well as trigger the inflammatory response. So in this situation, if for some reason someone has a defect in their pseudostratified ciliated columnar epithelial tissue, you know what another name for this is? They also give this another name. They call it the mucociliary escalator. And the mucociliary escalator designed, again, to be able to beat the bacteria, foreign pathogens, mucus up towards the mouth to be able to spit it out or swallow it. If there's some type of defect with the mucociliary escalator, for example, people who smoke, there's going to be more damage to these cilia. Are they going to be able to beat the bacteria and other substances up? No. That means that more bacteria are going to be able to colonize in this area. That's not good, because whenever they colonize, they can start leading to tissue damage, inflammation, infection. Another situation, cough reflex. Normally this should be activated whenever there's irritant receptors within our actual bronchi, and whenever they're activated, they send afferent fibers via the vagus nerve to your respiratory center in the medulla. Activate the efferent fibers of the vagus nerve, which then will, efferent fibers of your intercostal nerves and your phrenic nerve to trigger the cough reflex, to be able to spit that stuff up. But what if someone is taking opioid analgesics, right? Hydrocodone, fentanyl, morphine, things like that? That's going to actually inhibit the cough reflex. What if they're taking antitussives, right? So anti-cough medicines, that's also going to inhibit the cough reflex. Even alcohol, other sedatives, damage to the brainstem. Those are all things that can make them less able to trigger that cough reflex and spit that bacteria out. And the other thing is macrophages. Macrophages, they can be damaged by smoking as well, and even by excessive alcohol consumption. So for any reason, whether it be due to the defect in any of these normal mechanisms here, that can lead to a colonization of bacteria, or if there's a really nasty bacteria. Sometimes it doesn't even matter if you have all these things. Sometimes the bacteria is just so hardy and so dangerous that it can still produce tissue damage and lead to pneumonia. So again, we're going to talk about a bunch of causes, bacterial, viral, and fungal, but I want you to remember the most common one is bacterial. So let's pretend here for a second that we have a bacteria. Okay, so here we're going to have our bacteria, and here's these little evil guy, right? He's ready to produce some tissue damage. So what is he going to do? Well, these bacteria, you know that they can release a bunch of different types of toxins, right? So they can release different types of endotoxins. And these endotoxins can start producing tissue damage, right? So you're going to start damaging these tissues. When these tissues are damaged, what are some of the chemicals that are being released in response to tissue damage? Well, some of the big ones is going to be your leukotrienes. One that I really want you to remember is really important here is going to be your leukotriene B4. Leukotriene B4 is a really important one. The reason why is it moves into the circulatory system and acts as a chemotactic agent. In other words, it's a chemical that draws white blood cells and other different immune system structures into this area where the infection or inflammation is occurring. That's important. Another thing is bacteria also have particular amino acids that we don't have. Specifically, we have methionine. They have what's called informal methionine. So sometimes this informal methionine can actually get into the circulation, and again, that can cause chemotaxis. But here's where it really gets bad. Remember, there's all this tissue damage. In response to the tissue damage, you're going to have some other different leukotrienes and prostaglandins. So you're going to have some other leukotrienes. One is going to be your leukotriene C4, your leukotriene D4, and your leukotriene E4. And what these are going to do is they're going to start binding on to these different endothelial cells here. And it's going to increase the capillary permeability. Now, what does that mean? So let's say that I actually cause these spaces. I'm going to start increasing the spaces here. When I increase the spaces, I'm going to allow for more fluid to start leaking out. And as fluid starts leaking out, we start experiencing this edema, this inflammation. Another thing that starts happening besides the increase in the vascular permeability is whenever there's tissue damage, it activates mast cells. Mast cells produce a really important chemical. That chemical is called Histamines. Histamines will actually act on these blood vessels and cause them to dilate. Not only will it cause them to dilate, but it'll also increase the vascular permeability. So now you have more vascular permeability, you have more blood flow coming to this area. Why do you want it to be so permeable? Why do you want there to be so much blood flow coming to the area? Well, there's an infection. I want to bring my white blood cells, my complement proteins, all these different structures to the area to fight off that bacteria. That's a good thing, but at the same time, it's also going to start causing what we know as pneumonia. Another thing that happens here is besides having a lot of this edema due to the vascular permeability and besides the vasodilation, is leukotriene C4, D4, and E4 also bind on the respiratory smooth muscle. What do you think it's going to do to the respiratory smooth muscle? It's going to cause it to constrict. So at the same time, this leukotriene C4, D4, E4 is going to cause bronchospasming. That's going to cause some of the symptoms that we'll see like dyspnea, shortness of breath. Here's the next thing. With macrophages, they encounter these bacteria, right? So the bacteria started to produce damage. It just caused this inflammatory response. The macrophages come here and they try to interact with it, engulf it. When they do, they release more chemicals that just continue to increase this whole inflammatory cascade. What are some of those chemicals? Interleukin-1, tumor necrotic factor alpha, and these are really important. The reason why is these, again, help to increase vascular permeability, but they also induce what's called pyrexia, fever. That's why sometimes when people have pneumonia, one of the signs is they're going to have a fever. Other chemicals that they release, not super important, but they can release more chemotactic factors. Again, some of those chemotactic factors that they can release is like interleukin-8. So it can release other chemicals here, like interleukin-8. And interleukin-8 can also act as a chemotactic agent. So let's sum up what we have here so far that's caused all of this inflammation and edema and stuff like that. Again, bacteria colonized due to maybe these systems, these pulmonary defense mechanisms not working, or the bacteria is just so hardy and so dangerous that it didn't even matter that these defense mechanisms were here. He comes to the area, produces endotoxins that cause tissue damage. Overall, even if you don't want to remember all of these different chemicals, just remember what's the overall effect. They're going to start releasing inflammatory mediators of inflammation, histamines, leukotrienes, prostaglandins, platelet activating factor. What are those going to do? Big thing, cause the vessels to dilate and increase the permeability so fluid starts leaking out. That's going to start allowing for more white blood cells, more complement proteins, more inflammatory structures to come to the area to fight off the bacteria. Next thing, macrophages try to come and fight with the bacteria. Whenever they do and they engulf it, they start releasing cytokines to let more white blood cells to come to the area. What are some of those cytokines? Interleukin-1, tumor necrotic factor alpha, and what is the important thing I want you to remember that? It can cause pyrexia, okay? Now, after all of this inflammation happens, this is a stage within the pneumonia that we start to experience, because what are we going to start having in this area? If I were to draw like a little mini thing here, another mini alveoli. So imagine here I have another mini alveoli, okay? And then here I'm going to have my capillary, right? And just to sum up some of this stuff here, what do we have happening? Well, the first thing was vasodilation. That's going to start causing a lot of fluid to leak here into the alveoli. This is the first part that we start to experience within day 1, day 2 of the infection of pneumonia. This stage here, this first stage, is called congestion. So this is the first stage. This is usually around days 1 and 2, okay? This is, again, due to all this inflammation, vascular permeability, vasodilation. Second thing, sometimes what can happen is as this inflammation starts occurring, remember we said macrophages will start releasing chemotactic factors, so will these other chemotactic factors cause white blood cells to come to the area. Now there's going to be fluid, which is going to be an exudative fluid, meaning it has a high specific gravity, meaning it has a lot of proteins in it. Now you're going to have white blood cells, and if the pulmonary capillaries become damaged so much, guess what else can start leaking into the area? Red blood cells. So then you're going to start experiencing what's called red hepatization. So we call this red hepatization. And this usually appears around days 3 to 4. So this is usually around days 3 to 4. And again, what is this? Remember, we have the alveolar exudate. So here's this blue is going to be the protein and the water and all the different plasma components. Okay, that's congestion. Days 3 to 4, you're going to start having what other things? You're going to have white blood cells and red blood cells if the pulmonary capillaries start becoming damaged. And something else that might even accumulate in the area is fibrin. So then you can have some fibrin. This whole thing right here is the red hepatization. And this has another term that we're going to talk about, and this is called consolidation. This is the classical sign, consolidation. This is a classical thing with pneumonia. It's all this alveolar exudate, white blood cells, red blood cells, fibrin. Now this is days 3 to 4. What happens is, usually around days 4, about day 7, is you experience this thing called gray hepatization. So let's write this here, gray hepatization. What this is your red blood cells start getting destroyed. And as the red blood cells start getting destroyed, they start taking on a different appearance, this gray appearance. And again, this is usually going to be days 4 to 7, okay? So we start having alveolar exudate, red hepatization, and then gray hepatization, which is the breakdown of the red blood cells. Now, what should happen is generally the 4th stage. The 4th stage of this consolidation, this is classical of what's called lobar pneumonia. And we'll talk about what that means, but that's one of the most common pneumonias that you will be exposed to is lobar pneumonia, which is classically seen with consolidation. What happens is the 4th step is it should lead to resolution. Let's do that one here in purple. So resolution. So what that means is this is usually from days 8 and up. So days 8 plus, okay? What you start to experience here is there's going to be a breakdown of all of this gray hepatization. There's going to be the breakdown of more of the red blood cells, the white blood cells, the fibrin, all of that stuff. We're going to start trying to clear that out. Now, some of it will get broken down completely, but some of it will actually get coughed up. Now, that's important. The reason why that's important is if someone does experiencing lobar pneumonia with consolidation, when you have this resolution, this breakdown of all of that structures there, this consolidated material, you're going to have a sputum, a cough that's actually more what's called productive cough. So you're going to see that sputum production, and that is another important sign of pneumonia. So we've already been able to isolate a couple symptoms that we can already notice with pneumonia: dyspnea and shortness of breath due to that bronchoconstriction, fever due to the tumor necrotic factor alpha and the interleukin 1. You're also going to have a lot of inflammatory exudate there, and that inflammatory exudate is going to produce consolidation, which is also going to cause, this can lead to hypoxia if really, really bad. And if it resolves, you're going to start having that sputum that we'll experience with the cough. And we'll talk about some other things that you'll see here, because with consolidation, just remember what can happen. This alveoli, is it properly ventilated? No. Go back to physiology. What does ventilation go with? Perfusion, your VQ ratio, which is normally approximately 0.8, right? Now, if your ventilation is decreasing, this number is going to decrease. So what do we have to do to the perfusion? Well, now if this is decreasing, this number is going to go down. I want the number to go back up. So I have to have my perfusion drop. So guess what happens? Not only do I have poor ventilation, but I'm going to try to constrict the capillaries that are going to this poorly ventilated area to prevent them from going to this area where there's no proper ventilation. Send them to some other area of the lungs where there is proper ventilation so that we can get a good perfusion there. Okay? So that's important, but again, because of this, they'll experience hypoxia, and hypoxia can actually induce tachycardia and tachypnea. So those will be some other signs that we'll see as well. Okay, so that covers the pathophysiology. We're going to move into the causes now. All right, so now, Causes of pneumonia. We know that pneumonia, we've already said that it's most commonly caused by bacterial infection. How much of them? Usually 75 to 80% of pneumonias are usually bacterial in origin. There's viruses and fungi. We'll put a little tidbit on there about those, but it's mainly going to be bacteria. So what are some of these bacteria that we are going to come across specifically? Well, one of the big ones that I want you guys to remember is strep pneumo, okay? Strep pneumo is a really, really important one. The reason why is 65% of community-acquired pneumonias are due to this strep pneumo. It's a gram-positive bacteria, okay? Gram-positive. The next one is going to be Haemophilus influenza. We're going to denote that as H flu, okay? H flu. Haemophilus influenza is a gram-negative bacteria. Now, what's important about this guy, he's the second most common cause of community-acquired pneumonia. And we'll talk about what community-acquired, hospital-acquired, healthcare-associated, and ventilator-acquired, all of those are. But this is most commonly from community-acquired. Now, why do this is important? Because this is common in those with underlying pulmonary diseases, COPD, asthma, bronchiectasis, cystic fibrosis. Okay, so that's important to remember that you can see H flu and usually some underlying pulmonary pathology. Another one that we're going to come across is going to be mycoplasma. So mycoplasma pneumonia. Mycoplasma pneumonia is interesting because it's not even really it's not a gram-negative, it's not gram-positive bacteria because it doesn't actually have a cell wall. One of the big things about mycoplasma pneumonia is this actually occurs in people who are of college school age, so it's usually in younger individuals. Now this is a type of atypical pneumonia, and it's the most common cause of the atypical pneumonias. Now with this mycoplasma pneumonia, they also call it walking pneumonia. You'll see other symptoms that come up that are pretty helpful in your diagnostic sense. So sometimes what you'll see is they can produce these things called bulla or bullous meningitis. A bulla is just kind of, it's a skin lesion. It's a circumscribed deposit of serous fluid, and it actually comes on the tympanic membrane. And there's also some inflammation of the tympanic membrane. That's one situation. Another thing is they also show some signs of pharyngitis too. So that's important. Usually people of school age, high school, college, and they can show signs of some E and T situations like bullous meningitis and pharyngitis. Another situation, and this is an intracellular parasite. So we have to be careful with this one. We have another one called chlamydia, okay? So there's another one which is called chlamydia, and this one can actually cause it, chlamydial pneumonia. Another one is called Legionella. Now Legionella is a gram-negative bacteria. This one is interesting. This is the one that you can actually develop. It's not from person-to-person transmission. It's actually through contaminated water sources. For example, cooling towers, air conditioners. These are some things where it's more common you can develop these infections. Now here's another thing with Legionella. It presents with other things that usually show up, like GI symptoms, nausea, some vomiting. They also can show things like increased liver function enzymes, ALT, AST, those enzymes, ALK-Phos, and they can show signs of hyponatremia, decreased sodium levels within the blood, and that's important. All right, so Legionella. What are some other ones? Another important one is called Staph aureus. Now this is a really, really nasty bacteria, particularly if it is methicillin resistant, so MRSA. This one you can get, it's actually common post-viral infections, so post-viral upper respiratory tract infections. And remember I told you a little bit that it can be through hematogenous spread in those individuals who are IV drug users. So that's another situation that you want to remember. It can even be in those who are immunocompromised or elderly, okay? So that's Staph aureus. Another one that's important is called Klebsiella. This one is kind of like one of the interesting ones. Klebsiella is common in individuals who are chronic alcoholics. So people who are chronic alcoholics have an increased susceptibility of developing pneumonia due to Klebsiella. Another thing is it can also be common in people who are aspirators, who have some condition that make them more susceptible or prone to aspirating. Remember aspiration pneumonia. And this one is also seen as some certain chronic illnesses that, again, put them into an increased susceptibility of developing pneumonia. Some other ones is going to be Pseudomonas. So this is a really, really important one. I want you guys to please don't forget about this one. It's called Pseudomonas aeruginosa. This one is seen in individuals who are immunocompromised, so HIV, AIDS, or they have some type of structural abnormality of the respiratory system, cystic fibrosis or bronchiectasis. So again, that's another important one to not forget. Okay? So these are some of the big bacteria that I don't want you guys to forget about, okay? Now, what are some other causes? It's not just bacterial, but you also have viral. So what are some viral causes? Here, there's not many viruses. We'll throw these puppies right here. So viral. What are some viral causes? Well, one is called, you might have actually heard of it, it's called respiratory syncytial virus, RSV, or the parainfluenza virus. So one situation could be RSV, respiratory syncytial virus, or the parainfluenza virus. This is more common within infants and in young children. There's another one which is called your influenza virus. This one is another one, but it's more common in adults. And here's the really interesting one. This one is called CMV, cytomegalovirus. Cytomegalovirus can also cause pneumonia, but it's particularly in people who are like status post-transplant, so they've had an organ transplant, or they're immunocompromised, like AIDS. There is another one, we can put it in there. It's really severe in adults. It can cause some pretty nasty pneumonia. That's just called varicella zoster. Okay, so that's our viral causes. Now the next one is fungal. So fungal is an interesting one. Fungal ones are a little bit more common in certain areas of the US or other of the world, but they're also common in those who are immunocompromised. One of the really common ones in those who are immunocompromised, particularly those with neutropenic fevers or HIV/AIDS or immunosuppressive disease or taking immunosuppressive drugs. This is called, it's called pneumocystic jirovecii, but they also call it pneumocystic pneumonia, PCP, not the drug. Okay, pneumocystic pneumonia or pneumocystic jirovecii, common in those who are actually immunocompromised. That's a really important one. Another one is called histoplasmosis capsulatum. Histoplasmosis. Histoplasmosis, this is a beautiful color. Histoplasmosis is actually seen in the Mississippi river valleys or in the Ohio river valleys, where there's a lot of bird and bat droppings. So there's increased chances of developing a fungal infection, particularly with pneumonia. Okay? Another one is called coccidioides. And coccidioides is particularly within the soil, like in the southwestern United States or in California, so in desert areas. There's an increased chance of developing infections via these. But again, the one I want you to remember here, which is the most important, the most common cause, is bacteria. Please don't forget this. This is the most common cause. Another nice thing is viral, generally we don't have to treat these. They usually take their own course over a period of a couple weeks. Fungal, we usually treat with the antibiotics as well as some type of antifungal as well. But we're going to mainly focus on bacterial, okay? So we have our causes. Now what we're going to do is we're going to move into the clinical settings, okay? So when we talk about pneumonia, we can kind of categorize them about how they were acquired, if you will. So what do I mean here? One of the big ones that we see a lot is called community acquired pneumonia. And this is abbreviated CAP. All right? So that's what we'll see, community acquired pneumonia. Now, community acquired pneumonia, it's simple. It's pneumonia that was acquired while in the community, but we got to be careful. So it is a pneumonia, so acquired in community, but we have to throw this little tidbit in there, or in hospital less than 2 days or 48 hours. So we can also say that they can have community-acquired pneumonia if they've been admitted into the hospital, but they have had to be in the hospital less than 2 days. Okay? So that's what we'll talk about with community-acquired pneumonia. So community-acquired pneumonia is pneumonia that can be acquired from the community, or when you're admitted into the hospital, it has to be less than 48 hours or 2 days. Now, community-acquired pneumonia, there is some particular bacteria that are more common with this. Okay, so what are some of those? Let's use this pretty color here. So some of the big ones, the most common bacteria here is going to be your strep pneumo. So your strep pneumo, don't forget that one. Okay, your Haemophilus influenza, your Mycoplasma pneumonia, your chlamydia. So chlamydia is another one. Another one, which is called Legionella. And here's the last one that I want to mention, and I didn't mention it up here, but it can happen. It's called Moraxella catarrhalis, and it's particularly common in those who have some underlying pulmonary disease, most commonly COPD. So again, another one that you can see here is called Moraxella catarrhalis. And you can see Klebsiella here as well, but I'm not going to include that one here. It's more common in hospital, but again, just to be aware, you can see it in community-acquired as well. All right, so this is the ones that I want you to remember. Community-acquired pneumonia, specifically, these are the common bacteria that you'll see with it. Now, the next one is you have what's called hospital-acquired pneumonia. Let's do this one in this color here. I like this one too. So, hospital-acquired pneumonia. We'll abbreviate this HAP. Now, hospital-acquired pneumonia, it's simple. Acquired within the hospital, but how long does it have to be? How long have they had to be admitted into the hospital? Greater than 2 days. So it's simple, right? So hospital-acquired pneumonia was acquired from hospital after being admitted greater than 2 days in the hospital. So you've had to be in the hospital greater than 2 days in order to be able to say that it's hospital-acquired pneumonia. Now, hospital-acquired pneumonia, here's the thing with this bad boy. This one gives some really nasty bacteria. The reason why is when you're in a hospital, you have to think about it. People are really sick. And so they're going to have some really nasty pathogens that they can pass on this what's called virulence or even resistance. That's what you got to be careful of. So specifically, I want you to remember this. With hospital-acquired pneumonia, they can develop these things called multi-drug resistant pathogenic bacteria. And this is what's really dangerous about hospital-acquired pneumonia. That's why staying in the hospital for a long time or having some healthcare-associated procedures or ventilator-acquired pneumonia, these things are all really bad because there's a chance of developing some multi-drug resistant pathogenic bacteria. What that means, resistance in the simplest way, is they develop enzymes like beta-lactamases that are produced to break down the beta-lactams, which is your penicillins, your cephalosporins, your carbapenems, your monobactams, and render them ineffective. Which, how is that going to benefit you trying to be able to treat the underlying cause, which is the bacteria? Now, what are some of the bacteria that you see here with hospital-acquired pneumonia? So the ones that I want you to remember here is going to be your specifically Staph aureus. But here, let's actually make it more specific. Because with Staph aureus, you can even see Staph aureus in community-acquired pneumonia, but it's not MRSA. It's methicillin sensitive, so they're not resistant in community-acquired. In hospital-acquired, they're usually resistant. So MRSA is one. Remember the other one I told you? Pseudomonas. So Pseudomonas aeruginosa. Another one, Klebsiella. Another one is going to be your enterobacteria, your actinobacteria, and some other ones which are going to be like Serratia. Serratia is another pretty nasty bacteria that is also seen here as well. But again, the main ones I want you to remember is MRSA and Pseudomonas. These are the really, really nasty ones. And if you want to remember some extra ones, Klebsiella, enterobacteria, actinobacteria, and even some Serratia. Two other types of pneumonia, I'm just going to list them here. We're not going to talk too much about them because they're kind of like subtypes. One of them is called ventilator-acquired pneumonia. And ventilator-acquired pneumonia, you can put VAP. And all it is this happens when someone has been intubated. So endotracheal tube intubation for greater than 48 to 72 hours. They have an increased incidence of developing pneumonia because they can form these biofilms, which are pretty nasty stuff. Another one, which is kind of a subtype of community-acquired pneumonia, is called healthcare associated pneumonia. Now I'm going to put HCAP for this one. Briefly talk about this one. HCAP is common in those who are a resident of a long-term care facility, like a nursing home, or they receive home infusion therapy, or they get chronic dialysis treatment, and particularly within the last 30 days, if they're coming in to be seen. They have some family member with a multi-drug resistant pathogen who is at high risk, or they've had some they've been in an acute care facility for 2 or more days within the past 90 days. These are all things that increase the risk factor for healthcare associated pneumonia, okay? So again, big ones I want you to remember, the more important ones: community-acquired pneumonia, hospital-acquired pneumonia. Acquired in the community, or being in the hospital, admitted into the hospital, but it has to be less than 2 days. Here's the bacteria that are most commonly seen with it. Hospital-acquired pneumonia. Usually whenever the patient is admitted into the hospital and they've been in the hospital for greater than 2 days, or they've developed a multi-drug resistant pathogen. They don't have to develop a multi-drug resistant pathogen, but it is seen especially when they're in the hospital greater than 5 days. And then there's the 2 other subtypes here, which is ventilator-acquired pneumonia, which can be after endotracheal tube intubation, 48 to 72 hours, or healthcare-associated pneumonia, and we've already talked about all those in detail, okay? All right, so what we're gonna do is we're gonna talk about the 2 different types of presentations or symptoms that can be seen with someone with typical and atypical pneumonia. Now, we've already talked a lot about the typical things that we'll see here. So what have we said? We said that, remember, there's going to be a lot of that consolidation. That consolidation, which is the accumulation of alveolar exudate and red blood cells and fibrin and white blood cells and all that stuff there, that it can lead to dyspnea, which can lead to hypoxia. Hypoxia can increase your heart rate and increase your respiratory rate. So what are some of the things that you'll see upon initial inspection of the patient, or you're getting their vital signs? You'll see tachycardia, so you'll see an increase in their heart rate. You'll see tachypnea, increase in the respiration rate. Now, a little bit on that, just remember that all it is whenever there is hypoxia or this consolidation, CO2 levels build up in the blood. It stimulates your central and peripheral chemoreceptors. What do those do? That activates your respiratory center in the medulla and increases the rate and depth of the breathing. That's where you get the tachypnea. But there's another interesting reflex that whenever the chemoreceptors are stimulated, not only do they activate the medullary respiratory centers, but they activate the cardiac acceleratory center, which then increases your heart rate. So those are things that you'll see. We said pyrexia or fever. We'll see that. Remember, whenever there's complete resolution of the consolidation, we can see some productive mucopurulent sputum. So we'll see a cough with mucopurulent sputum production. And there's something that we can talk about with cytology. We'll talk about in the diagnostic workups. But the next thing that you can experience here is, besides that, you're also going to notice that they'll have some other extrapulmonary symptoms. Fatigue because of the hypoxia. So they'll have fatigue. And another thing that they'll see is dyspnea. So they'll have shortness of breath. So they'll have shortness of breath. These are going to be some of the main things that you're going to see with a patient who is having typical presentation of pneumonia. What do I mean by typical? Bacterial in origin. All of these bacteria that we've already mentioned. The other one, let's do this color here. Your atypical, this is going to be more for those special bacteria that we talked about. Remember the mycoplasma, the chlamydia, the legionella, viruses, fungi, all of those are atypical. They don't generally present with any increase in respiratory rate or heart rate. They generally present with extrapulmonary symptoms. So what do I mean? They present with like a headache, some nausea, maybe vomiting, maybe diarrhea. Another thing that they do is they actually present with a significant fatigue and malaise. So they can present with fatigue, malaise, and a lot of muscle pain, so myalgia, okay? Now, they can have a fever, but their fever is usually very low grade. So they can exhibit a fever, but the fever is usually a very low-grade fever. So low-grade pyrexia. And here's another big one. Remember, this one was a cough with a sputum production. It was a productive cough. Usually those with atypical pneumonia, it's a dry cough. So it's mainly a dry cough. Okay, so these are some of there's many other symptoms that we can see, but these are the most common ones that you're probably going to see whenever you're seeing a patient with typical or atypical pneumonia, okay? All right, engineers, so in this video, we've talked about the pathophysiology of pneumonia, we've talked about the causes, we've talked about the clinical settings, we even went into the signs and symptoms. What we're gonna do in the next video is we're actually gonna go over the diagnostic workup. So specifically, we're gonna have a patient that we're gonna try to replicate what you would see upon inspection and palpation and percussion and auscultation. We'll have some chest x-rays that we're gonna look at and see if we can point out those abnormalities. And then we'll come back to the board and we'll talk about other signs that we could see in the diagnostic workup. We'll talk about blood tests and urinalysis and things of that nature. But I want to say thank you guys for watching this video. If you guys could, please go visit our GoFundMe page. We'll have it in the description box. If you guys could donate whatever amount you can, we would truly appreciate it. Everything that goes from that GoFundMe page is directly funneled into getting us better equipment, helping us to pay for editing software, and all the things that we need to provide these free videos for you guys' enjoyment. Also, check out our Patreon. If you guys could donate there, we would truly appreciate it. Check out our Facebook, our Instagram account. We just want to make sure that we're in constant communication with you guys and letting you guys know what's happening and what we're going to be doing next. And as always, Ninja Nerds, until next time.